Welcome to the Benefit Whisper, the show where we pull back the curtain on what's really driving your healthcare costs and what you can do about it. Hello, this is Ralph Weber, and I am the Benefit Whisper. For our 4th of July long weekend episode, we're going to talk a little bit about the ACA and some of the provisions of the ACA and what an employer can do about it. It's very important. The ACA, or Affordable Care Act, sometimes known as Obamacare, was enacted about 15 years ago now, and it brought many changes. It was the most sweeping reform of healthcare for decades. The Affordable Care Act was supposed to make healthcare more affordable and more accessible. Now, it does allow people with pre-existing conditions to sign up once a year on the individual exchange, so it did do that. The affordability, it provides subsidies for some people based on income, so it doesn't really make the health insurance per se more affordable, but what it does is it provides subsidies. So it's subsidized healthcare. Now, the important thing about the ACA is one of the provisions is it required what's called an applicable large employer, or ALE, to provide certain types of coverage. Now, what is an ALE? That's an important starting point. An ALE is an applicable large employer. It is an employer that has 50 or more full-time equivalent employees. Now, it's important to note that a full-time equivalent employee is not the same as a full-time employee. A full-time equivalent is one or more people working 30 hours a week or 130 hours a month. So, for example, two people that each work 15 hours a week equals one full-time equivalent, or three people working 10 hours equals one full-time equivalent. So you could, in essence, have 150 people, each working 10 hours a week, and have 50 full-time equivalent employees without having a single full-time person. So that's very important. The other really important thing is the control group rules. A lot of people have one or more businesses, maybe that they own with their spouse, with another partner, etc. So only your accountant, your CPA, or your attorney can really tell you for sure whether you are a control group. But in a nutshell, and these are just rule of thumb type rules. If you own 50% of two or three businesses, or let's even keep it safe, 51% of two or more businesses, you control each of those businesses. So they are combined for the purposes of determining your control group, determining whether you have 50 or more employees. So that's an important starting point. Now, each of these employers could have different set of benefits because they might be in different industries. They don't have to have one plan for all, although they can. So this is an important starting point. So let's start there. Now, what happens? The applicable large employer is required to offer minimum essential coverage or face a fine under IRS code 4980HA, sometimes known as the sledgehammer penalty or the A penalty. So by offering at least minimum essential coverage, you check that box. The second mandate is 4980HB, sometimes known as the tack hammer penalty. Now, let me back up to the 4980HA. If you do not meet that standard, your fine is $2,900 per year per employee. The first 30 are exempt. So, for example, if you have 100 employees, it would be $2,900 times 70. The B penalty, or 4980HB, is $4,350. These are all 2025 numbers. So $4,350 per employee. Now, there's a kicker to this. There's fine print. To meet the 4980HB mandate, you have to offer minimum value coverage. Now, minimum value, let's see, let's just call it like a regular major medical plan. So a minimum value plan has to offer 60% actuarial value. In other words, 60% of the services that are generally consumed by a person. The carrier, the insurance carrier, or the third-party administrator can determine whether that plan meets minimum value. So if you offer a plan that is minimum essential coverage and provides minimum value, that's a start, but there's more. The plan has to be affordable. And affordable means that you can't ask your employees to contribute any more than 9.02% of their wages. So let's just call it 9%. So if somebody earns $2,000 a month, you cannot ask them to pay more than $180 a month. If you ask them to pay $190, it's not considered affordable. Now, this is for self-only coverage, just for employee coverage. It doesn't consider their family. You can charge them the entire amount for their family, and as an employer, put in a greater amount to the employee-only coverage. So, minimum value, affordable plan. Now, if this one is different, instead of as in with the A penalty where it's assessed on all of your employees, this is only assessed on the employees that go to the exchange, purchase a plan, and get a subsidy. Now, number 4, and they're not enrolled in your minimum essential coverage plan. And still, we are going to get to describe what that is. So if they're not enrolled in your minimum essential coverage plan, they go to the exchange, they get a subsidy, and their income, in order to get a subsidy, has to be between 100% of the federal poverty line and 400%. In some states, it's between 138 and 400. Now, how do you determine what that is? That's based on the entire household income. So you might have a low wage employee, but they may have a dependent or a spouse that earns more money that goes into the household income. So that threshold could be higher. Even if they get a subsidy of $1 per month, then you're subject to that fine. Okay, so let's talk about minimum essential coverage, exactly what that is. There are plans on the market called MEC plans, MEC, MEC. And what that means is a MEC plan is the kind of plan that it offers only preventive care. So minimum value coverage has to be affordable, and only the people that qualify for a subsidy based on their entire adjusted gross income of the family can get a subsidy. Now, let's get back to what a MEC plan is. MEC plan stands for minimum essential coverage. Now, first of all, one of the things that the Affordable Care Act did prior to the ACA, there was an act called the McCarran-Ferguson Act, which was passed in 1946. The McCarran-Ferguson Act said each state will regulate insurance in their own state. So since 1946, health insurance is regulated state by state. The Affordable Care Act said each state will set its own essential health benefits out of 10 categories, categories such as prescription drugs, primary care, inpatient, emergency, et cetera, et cetera. So each state set its own standards, and any state-based fully insured plan has to meet those essential health benefits. Now, self-insured plans are governed under ICHRA and overseen by the Department of Labor. The plans that are self-insured, sometimes they have stop-loss insurance. Just because they have stop-loss doesn't mean they're fully insured. But a plan that is overseen by the Department of Labor, a self-insured plan, is different. Self-insured plans are governed federally by the provisions of ERISA, ERISA, and overseen by the Department of Labor. Now, when the Affordable Care Act said each state shall set its own essential health benefits, they never said, and the federal government under ERISA will set essential health benefits. Therefore, any self-insured plan does not have to meet essential health benefits. The minimum standard for a self-insured plan is minimum essential coverage, or a MEC. Now, a MEC has to be a self-insured plan. It has to be offered on an employer-employee relationship basis. And what a MEC plan has to cover is the approximately 78 mandated preventive care services. Now that changes all the time, the number. Sometimes they add some, sometimes they take some. There's legislation right now in Washington that might change the preventive care. But the things like pap smears, mammograms, annual physical, believe it or not, baby aspirin is covered, things like that, things that are preventive in nature. Okay, so in other words, if you have to go in and say, I'm seeing these symptoms, that's not preventive care. that's diagnostic. So to meet the preventive care mandate, those 78 items have to be covered at first dollar, meaning you can't ask the employee to pay a copay, coinsurance, deductible, etc. So you have 78 services that have to be covered at 100%, and they have to be covered with no deductible, copay, etc. Now, the interesting thing about that is the minimum essential coverage itself, because it only offers preventive care, it doesn't really add a whole lot of value other than checking that one box. So we have developed plans, MEC plans, that are sort of enhanced. For example, we have a MEC plan that is compatible with an HSA, a pre-tax HSA or health savings account. We have MEC plans that are coupled with DPC or direct primary care, which offers unlimited primary care, some labs, some generic drugs, etc. So some of these MECs are a little bit more robust. We actually even have some MECs that don't meet the minimum value standard, but have some hospitalization emergency room coverage. A MEC plan can be as little as 78 preventive care services covered at 100%, or as much as hospitalization, imaging, emergency room, etc. And it allows you some flexibility, but at the end of the day, it's still, generally speaking, although technically every minimum value plan is also a MEC, but something that's called a MEC plan usually isn't. So again, has to be self-insured, has to cover 78 preventive care services. Now, if you have a PPO network, such as Cigna, First Health, Aetna, etc., then those charges are subject to the what's called the allowable charge. And it could end up being very expensive. Another way to do that is what's called reference-based pricing. We had an episode with Adam Russo a few weeks ago. So if you want to know about reference-based pricing, check that. So a MEC plan with reference-based pricing can be relatively inexpensive, depending on the size of your group. And if you attach an HSA with that and put some money into the HSA, more people will sign up for your MEC plan. The more that sign up for your MEC, the less exposure you have to the B penalty. The first thing that developed shortly after was a QSEHRA, QSEHRA, Qualified Small Employer Health Reimbursement Arrangement. Now, that's only for small employers under 50. Then another thing that developed was called an ICHRA, ICHRA, Individual Coverage Health Reimbursement Arrangement. That's available for employers with 2 employees to 1,000 or more. So the ICHRA is growing in popularity, and we have developed some amazing ICHRA technology to administer these plans. What an ICHRA does is your employees go to their state or federal exchange, depending on what state you're in. They purchase an individual plan that meets the essential health benefits requirements, and you as an employer reimburse a certain portion. Now, you could say for people with single coverage, we'll pay up to $250 at 80%. In other words, if their plan costs $500, your cap is $250. If their plan is $200, then you'll cover 80% of that, or $160. The percent and the amount can vary by many, many different factors. So you can really tailor this, but it still has to be affordable. In other words, the amount they have to pay has to be less than that 9.02%. Also, an ICHRA disqualifies them from getting a subsidy. So as long as you offer these plans, whether it's a MEC, whether it's a minimum value, or whether it's an ICHRA to at least 95% of your people, and the policy goes into force, then you have checked that mandate. So the ICHRA can be a great tool. The one thing you cannot do with an ICHRA, you can't say, would you like this or would you like that? In other words, it cannot be a choice. It cannot be a choice of one or the other. An ICHRA has to be exclusively offered to a class of people or all of your people. So, for example, you could offer the ICHRA to your management staff or your salaried workers or your outside workers or any kind of a non-discriminatory class. You can offer the ICHRA. And then the other class that's left over, you can offer a different plan. It could be a MEC plan. It could be nothing. It could be a minimum value plan. So the ICHRA gives you a lot of flexibility. The good part about it is that every single person that goes to the exchange will qualify regardless of pre-existing conditions. The bad part is the plans on the exchanges are sometimes HMOs in many states. Sometimes there's not a lot available in terms of plans. So there's good and bad. Really, you need to speak to a very qualified benefit consultant and talk to that person about your situation. And an ICHRA should be one of the things that they consider. So an ICHRA is one way to check both penalties, A and B. A MEC is another. Let's talk just a little bit about self-insured plans, because as you recall, I said that any self-insured plan doesn't have to meet the minimum value requirements. Now, also with self-insured plans, you can carve out certain parts. For example, you could carve out mental health. You can carve out specialty drugs. You can carve out a lot of different high-cost things to reduce the cost of your plan. A self-insured plan, again, is governed by ERISA. You can have stop-loss insurance on it, which protects the plan from large claims. So usually for small employers and even up to 100 employees, the desired plan, if you're doing self-insured plan, is what's called a level funded plan or refund health plan, where you pay the maximum liability. And then at the end of the year, they look at your claims, they look at how many claims were paid, and you might have money back and you might get it back. Now, under ERISA, the third-party administrator or insurance company has to refund 100% of your excess unused claims fund. Now, on a level funded, we had a whole episode about level funded plans. On a level funded plan, you have three elements that go into the cost. You have the stop loss insurance, you have the administrative costs, and the claims fund. Now, the claims fund is segregated. It's kept in a separate account, usually. It should be all the time. And it builds up, and you as an employer should be able to look at that at any time and see how much is in your claims fund. And then come the end of the year, you should have access to 100% of your excess claims. The ACA, as I said in the beginning, was legislation that was meant to make healthcare more affordable. It did so by offering subsidies to certain low-income earners. Now, if their income is below 100% of federal poverty or 138 in some states, then they will usually qualify for Medicaid. So they have to be between that 100 and 400% in order to qualify for subsidy so that it becomes affordable. As I said earlier, there are pros and cons to the individual state-based exchanges. The pro is you can get coverage as long as you sign up at the right time of year or after a qualifying event. The con is that sometimes you have a narrow network, there are only certain doctors you can see, etc. So let's recap. If you're an applicable large employer, that means you have 50 or more full-time equivalent employees within your control group. If you meet that threshold, then you have to offer at least minimum essential coverage. Minimum essential coverage, also known as MEC plans, are self-insured plans that cover the 78 approximately preventive care services. They have to cover them at the first dollar, no copay, no deductible, no core insurance, has to be 100% covered. So to meet that MEC standard, you check off the 4980HA penalty. And to meet the B penalty, you have to offer a minimum value plan. The fine for the A penalty is $2,900 per person per year, except the first 30. Again, if you have 100 full-time employees, then you would pay $2,900 on 70 of them every year if you don't offer coverage. The 4980HB or tack hammer penalty, as it's sometimes referred to, or the B penalty, is $4,350. Now, the B penalty applies only if somebody goes to the exchange, gets a subsidized plan, and if you offer a minimum value plan that's affordable, that meets the actuarial value calculations of 60%, then just because they opt out, they can't go and get a plan on the exchange unless it's not affordable, unless it's not minimum value. So make sure that you do that. We also have some plans. Now, these are a relatively new development. We understand that a lot of employers don't have a huge margin. So what we've developed is a plan that's a MEC minimum value combo so that you can go on one or the other. It's all one plan. So there are many ways, many affordable ways for you to meet the mandate. Ultimately, if you can afford it, a minimum value plan is the best coverage, and self-insured plans offer much more value. Number one, you get your money back if the claims are low. Number two, as long as your group is relatively healthy, the premiums, if you will, would be lower in most cases than a fully insured plan. With a self-insured plan, you can carve out certain things. Some faith-based organizations, such as the Christian Employers Alliance, has a plan, and it carves out some of the biblically objectionable items. You can do that under the self-insured plans, cover a lot of things and make it more affordable and still meet the minimum value standard, but you have to be very careful that you still meet that standard. That is the utmost in flexibility. Anyway, if you want to contact us, call us at 832-924-3300 or email ralph@thebenefitwhisperer.com. Remember to click like, subscribe, share the episode if you feel that this could help somebody else. And we'll be back again next week with another exciting episode of The Benefit Whisperer. Thank you for joining today.